Okay, girls. Thank you, Darshna, and thank you, Enthasar, for sending me your submissions for this task 2 of Oxford Handbook. I'll quickly run the audios from you guys, and then I'll give you a feedback. Okay. So I'll just run Enthasar's audio briefly because I want to highlight few points, and then I'll jump to Darshna's audio. Okay.
Hello, I am Dr. Abdul Qadir, one of the doctor in the antenatal clinic today. May I confirm your name and age, please? Yeah, my name is Priya King. I'm 38 years old.
Okay, I have to make the point really quick because otherwise whoever is watching the video will find probably that the utilization of time is not the best one at this point. And Sir, I have a very huge concern here because the volume of your voice, this was very inconvenient for me. I was not able to listen, despite trying at least 4 times. I was not able to. I started getting a bit of a headache, really, because there's some problem with your volume. Okay, whether it's the device or whether you're talking too low. You're too quiet there. Okay, why I have tried to play here and why I'm trying to say this is that this is a general message for everyone, that please be very good with your voice, tone of voice, and your pitch, volume, everything. You want to be pitching at a level that the other person is able to clearly understand you. Okay, because when when you don't know anything and you are not scoring, that's of course a problem. But if you know and then still you can't score, that's a huge issue. Okay, you can't afford that kind of situation in the exam. So maybe once or twice the role player may say that she didn't understand, but then they'll stop bothering about that and they'll just think that it's not they won't be keeping repeating this request that they can't understand you clearly. Okay, so I have huge concerns. Anyone who talks so quiet and so low shouldn't really. They should focus on their speaking skills a lot. Okay, so I understand, Anthasa, you're very polite. Your English is clear. You have grammar issues, but and some phrases were a bit incomprehensible. But other than that, this is the biggest issue. Okay, the volume and the tone of your voice, that's the biggest issue. Even not only for the exam, I feel that if you're submitting here in the group, I'd still request that we hardly kind of try to find time for everyone, so it will make a best use of the time if this was addressed. Okay, and this is for all of you. Okay, so I may come back to your audio. Let me try to run it just 1 minute or 2 minutes, and then I'll switch to Darshana's.
Would you like to be addressed? Free is fine, doctor. Okay, Priya, thank you. Thank you, doctor. I understand from your committee midwife referral letter that you are committed.
So see now, after I've made my point, I have run this again for a few seconds. So you all know what I'm talking about. Okay, so this is too low. Okay, now I think I'll skip this one for now. Okay, and I'll go to Darshna's attempt. Okay.
Hi, I'm Dr. Darshna, one of the doctors in the clinic today. Can I confirm your name and age?
So first of all, this is a good tone of the voice. Okay, good tone, good volume. I actually had to, turn the volume to full for Enthasar. And for Darshna, I had to quickly stop and lower down the volume because, I don't want my full volume to reach the next room. So, but what I'm saying is that even on full volume, Enthasar's audio was not audible. Okay, and Darshana, you've done a very good job here. So this volume and tone, I'd like everyone to kind of try to be this clear. Okay, good.
Yes, doctor, I'm Freya King. I'm 38 years old. How would you like me to address you? You can call me Freya. Okay.
Yeah, good introduction.
Priya, nice to meet you. I have received a letter from your midwife that this is your first pregnancy and you are 41 weeks pregnant. Am I right?
I like this opening as well.
Yes, doctor. So, Freya, do you have any particular concerns that you would want to discuss today?
Okay, so this is an excellent question. Okay, I always recommend everyone to ask this question. Okay, so read out the referral like this is why you were referred, and then ask if there is any particular concern. That's an excellent question. Okay.
Yes, doctor, I would want to know the delivery plans or how can I go about, because I would like to continue with my pregnancy so far is my concern. Okay, Freya, I will address your concern. But since we are meeting for the first time, is it okay if I ask you a few questions to know more about you so that I can make a suitable plan for you? Yes, doctor, you can ask me. Okay, so Freya, can you tell me a little bit more about your pregnancy? Yes, doctor, so far.
So here I just want to say that we all meet the patients for the first time usually. So that's not really something that needs to be so, you don't need to be so concerned about that. But if it's your habit, then go ahead. That's not a problem as well. Okay. But yeah, we all meet with our patients usually for the first time. Okay, because they don't, when they're coming back, they are seeing our other colleagues. Sometimes they may come back to us. So it's absolutely okay not to say this sentence and just say, I have few questions, and you can proceed with that. Okay.
Has been a normal pregnancy. I've been visiting my midwife, and so far I have only visited the hospital only like during my scans, which also have been normal. So yeah, I do not really want go to any doctor to any visit anything. I do not require any medical help so far. Okay, I can understand that. So Freya, can you tell me, are there any pregnancies? Have you had any pregnancies before?
So here you see your mistake here. You had already asked her that this is your first pregnancy, and now you're saying that have you had any pregnancies before? So please don't sound like that kind of detached with your patient. You will sound like that you are not attentive. Okay, so just pay some focus. Okay.
Doctor, no other pregnancies. Okay. And what about, is your baby kicking well? Yes, doctor. Okay. Any other symptoms which is bothering you? No, doctor, nothing as such. Are you aware of your blood group? Yes, doctor, it's A positive. Okay. Do you have any blood reservations? No, doctor. All right. Any other medical condition for which you see your GP? No, doctor. And any surgeries in the past? No, doctor. Anyone in your family who has been affected with any condition? No, doctor. Okay. And do you have any allergies to food or drug? No, doctor, nothing that I'm aware of. All right. Are you up to date with the cervical smears? Yes, doctor. Okay. So, Freya, is it okay if I ask you a few private questions as we ask all women who come to us?
So, okay, I have two concerns here. One, you don't seem to be taking really targeted history. So this exam is at an ST5 level. In a couple of years, they'll be consultants. So they are considered as evolving consultants. Okay, they should know how to avoid untargeted history taking exercise. Okay. Other thing is that no smoking and alcohol and all these kind of questions are not private questions. They will probably not deduct your marks there, but you will sound like foreign there. You will sound like you don't practice or you're not aware of the practice in UK. Okay.
Will that be okay? Yes, doctor, you can go ahead.
So sorry, I forgot to mention that especially like you are asking about the cervical screening history and all that. So when I'm teaching my students, I kind of try to grill them a lot into taking only very targeted history. So you guys need to find a way to take targeted history daily, okay? And let's come back.
Okay, Freya. So do you smoke? No, doctor. Do you take alcohol? No, doctor. What about your support at home? The support is good, doctor. Okay. Have you been feeling low, down or depressed or taking less interest in the activities?
Yeah, mental health questions are good at this stage, okay? Even at this stage, okay, and at every stage. And, even domestic violence inquiry, antenatal care guidelines, they say that you should ask in each visit. But smoking and alcohol is not related to this visit, okay?
No, doctor, nothing that I don't feel like that. Okay. So, Freya, thank you for giving me all the information. So this is your first pregnancy, and you are at your 41 weeks of pregnancy. And so far, you do not have any symptoms, and you want to continue with the pregnancy and delay the plan for delivery. Is that so? Yes, doctor. Okay. So, Freya, can you tell me?
So this summarizing, RCOG says that's only for you. So if you have time, then summarize. If you don't have time, you can skip it as well. There's no marks deduction, and there are no marks for summarizing. Okay.
Why do you think, or what has made you think to continue with the pregnancy and delay the delivery plan? Any concerns that you have? Any fears that I can address?
Okay, this is a very good question. Excellent. Any concerns and any fears that I can address? I normally ask that right in the start, before even asking the history taking. That helps me, reshape my history taking. That helps me figure out if I need to ask any question regarding that. But if you are comfortable asking afterwards, fine. As long as you don't miss important things, absolutely fine. I'm not a great, um, um, fan of, talking about sequence, because as long as you cover the most important things, that's what actually matters. Okay.
Yes, doctor. What happened is my one of my sisters, one of my cousins, one of my friends had underwent.
This was lovely. So when this happens, when we are becoming our own patients, then it's very difficult task to juggle between the two roles. So I really enjoyed this, that you were not sure whether it's sister, a cousin, or friend, but that was nice to smile for a change.
Induction of labor at hospital, and it was a very bad experience for her. She was like the labor did not happen, and she had to undergo a cesarean section, and about a lot of blood was lost, and she was transfused with blood, and it was a very traumatic experience for her. So I'm a little bit afraid that I might not have to go through such conditions so far. Okay, Freya, I can see that you are concerned, and your concerns are valid since you have seen your friend getting affected.
Okay, so this is very good that you're validating her concerns. Okay, this is a part of a good communication. So I keep saying to everyone that good communication is not only that you're talking politely and softly and whatever, you very clear and all that. That's not only, that part is not communication. Communication is it includes, it encompasses the fact that you are addressing patients' concerns, you are sensitive to patients' concerns, and evaluating her appropriately and responding to her appropriately. Okay, good.
But let me assure you that this is not the case in everyone. Very few,
good.
It is very rare that such complications can happen. But yes, since there is a risk of, in spite of induction of labor,
rare
that there might be a requirement for cesarean. So the risk is there for everyone. But because we want a safe plan for you, what I can suggest you.
So when you don't remember how much is the risk, you don't have to commit to that, how much it is. Just say that I'll give you written, if you don't remember, that's fine. Say I'll give you written information, with some numbers comparing, various options with each other, and that will help you decide as well. Generally, this one is like this and this one is like this. So you're not really committing to any numbers there, but you are promising that you will give her some information from NICE guidance, which she can, go through in her time to look at the numbers and all that, if it helps her decide.
Is that I can give you some options. The safest option is to undergo induction of labor, as you have heard that before.
So actually the safest option is that if she ends up in spontaneous labor, not induction of labor, okay? So safest option is that, yes, you are 41 weeks. The safest would be that if, if nature works in our favor and you end up in spontaneous labor within few days and get delivered before 42 weeks, that's the safest option, okay?
Are you getting me, Sarah? Freya? Yes, doctor.
Yeah, try not to confuse the name in the exam, but here, of course, yeah, that's fine. You are just preparing and it's not a big deal here.
Okay, so this is a process to give you some medications to reduce the labor pains. Okay, doctor. So what we will do is we have to admit you and we can give you the medications and we can wait until the labor pains come.
Okay, so like giving information like this is again a bit tricky. Okay, no, it's not like she needs she doesn't always need to get admitted. Okay, because we do kind of do inductions when we can give them something and they can go home and then they can come when the labor onset is there, or they can report to us when if 6 hours have passed and nothing has happened. They call the labor ward to tell and we plan further. So that also is a way of inducing in recent years. Okay, so you may need admission. You will need to come to maternity unit, that is for sure. You will need to come to maternity unit for induction. Afterwards you may be able to go home depending on how case to case basis and how your midwife and your doctor are feeling at that time about yourself. Okay,
and we will expect a normal delivery. Okay, and there are chances that a cesarean section may be required. There are chances that a little more of blood may be lost because we are using other agents or other medications. Okay, and also sometimes if a cesarean is there, then the chance of having another cesarean.
So if the cesarean is there is not really good grammar. Okay, if we have to end up with a cesarean section, or if we have to, or if you have to undergo a cesarean section for any reason, then the risk of a future cesarean section will increase. Okay,
so increases. So these are some of the risks that are associated with induction of labor. Okay, doctor, I can see that. And if you want to prolong the pregnancy, there are some of the specific risks which are associated with the baby, and also with your.
So she doesn't really want to prolong the pregnancy. She doesn't want to interfere. She wants to stay natural. So that's again a bit of a, a little bit of a language issue here. Okay, so she doesn't want to prolong the pregnancy. You have to remember, she just wants to go natural. So if she's in a bad mood for whatever reason, maybe she didn't like the previous candidate. No, I'm just joking. It's not that if she doesn't like the previous candidate, she won't be showing her anger to you. But if she's told that she can be awkward or she can show some annoyance or irritation, then she may say, "Who says that I want to prolong my pregnancy, doctor?" So just be careful with the sentences.
Health. Okay, so for the baby, it can happen that the baby might open its bowels inside your womb, which can affect the baby and which can harm. There are rare chances the baby can die inside the womb. Okay, doctor. And I don't want to scare you, but since it's my duty to tell you that these things can happen, so these are necessary to know. Okay. Other risks to the baby are like having a larger baby, which can have problems during your labor, like the shoulders of the baby can be stuck behind your pubic bone. Also, there can be injuries to the baby. Also,
so you assume that she knows what a pubic bone is, yeah?
There can be perineal tears or tears down below for you. Okay, the chances of what we call as postpartum hemorrhage, which is excessive bleeding after the birth of the baby, are also there.
Okay.
Yes, that's
So
a
these
good
are some
one.
of the risks which are associated for a woman who goes beyond the expected
So for a woman, yeah.
date of delivery or beyond 42 weeks of pregnancy.
Mhm.
Okay. And because they are risk to the baby, we would want intensive monitoring for the baby because the fluid
So did you mention Erb's palsy at all? Yeah.
on the baby can reduce. We will advise you to undergo twice weekly cardiotocograph. Okay, doctor.
So cardiotocograph is a big jargon. Okay. So baby's heart monitoring.
And we would also want you to undergo a test to detect the size of the pocket or the fluid around the baby.
Yeah, test. So test for the size of the pockets. You're making it a bit complicated. Make it easy. Say you we offer you an ultrasound regularly for fluid around the baby. Okay, to see how much fluid is around the baby. That's it. No pockets there. And rather than calling it a test, say ultrasound. They know what an ultrasound is.
Okay, doctor. So I will still put you across to my consultant since you'll be able to know about the best option which is there for you. You can always go back.
So why you're bringing the consultant here? This is not really a negotiation failure, okay? And this is not a very high complicated discussion. So we should stay away from dumping all the regular work on the consultants, okay? That won't shine very good on your performance, that it wasn't required and you just dragged the consultant in there, okay? So it's this is something we can easily handle. We'll give her some reading material. I encourage her to speak to her family members. She can bring them in the next appointment. Like we can say, I can see you again tomorrow or day after tomorrow. So because we don't have much time, then she has to decide and then she'll have to be induced. So we'll say as soon as possible. So preferably tomorrow. We can see you. You can bring your partner or your mother or whoever wants to be, with you, or whoever wants to come and, um, see what we have to explain to you. Then you can bring them with you and we can talk about that. So it's still us. The consultant will be involved when there's a negotiation failure.
Home and discuss the options with your family member because you will need their support in your every step.
Good.
And I will provide you some patient information leaflets. You will get to know about the condition and how, which will you will get to know about your condition and also the best management option, which will be for you.
Yeah, okay. Here I was until this point hoping that you mentioned the big baby. I think Intesar mentioned the risk of having a small baby as well, and you forgot somehow. So it would be good if you remembered that baby can go small as well because of placental calcification and all that. So yes, whatever I was able to hear from Intesar's audio, she did mention that. Another thing that you haven't mentioned so far, and I don't think you have mentioned it at all in the audio, is an option of giving her a sweep. Okay. And Intisar gave her the option of sweeping, which was good. Yeah, we prefer the word sweeping rather than stripping that Intisar used. But yes, you haven't addressed that.
Okay, doctor. And any other help that you require? No, doctor. I just wanted to know that will it be harmful if I get admitted and go for induction of labor? Freya, I would like to tell you that there are always some or the other risk with every procedure, and for the sake of balancing the risks and the benefits for you, it will be
okay. So this is a good sentence.
More beneficial for you and your baby to undergo induction of labor. Rest, you can understand your decision and can discuss with a family member, and we are always there to help you. I will provide the patient information leaflet, and we can book another consultation with the consultant in our next meeting.
So one, you're repeating yourself. You just said that and you're coming back to the same thing. And again, the same thing, that no, not consultant.
And till then, if you want to get admitted, we have and if you want to get admitted, we are always open for you. And
No. Okay. So this is not how the system works. Like we are always open for you if you want to get admitted. So no, please. Inductions don't work that way. That way we only cater the patients who come in labor, okay, who come in spontaneous labor. We are open and they can come and all that, or wherever there's any complication. For inductions, they have to book the induction with us, okay? And only then when we give them the appointment, then they come. Actually, they even call before the appointment on that morning to see if we have a bed that was provisionally allocated to them. So then, they can come. So no, it's not like whenever you want to come, we are always open for you. That's not a correct sentence. Okay.
you can come and get admitted in the consultant-led unit. Okay. Continuous tachography or an electronic fetal monitoring will be there.
Yeah, make a habit of saying baby's heart trace will be monitored.
Done for your baby throughout your labor. And we will take a written informed consent from you. And as we go, we can have a midwife for you with continuous support. And yes.
So a written informed consent will not be taken when she has come in for labor. That will be taken at the time when she decides to go ahead with in the clinic, I mean, okay, when she decides to go ahead with the induction, then she will be signing that consent. And not all the hospitals are at the moment doing a written informed consent for induction of labor, okay, but it has started in some hospitals. Otherwise, we just used to book the induction and that's it. They didn't have to sign any consent form for that. But few hospitals have started doing that. It may become practice in many hospitals soon. We never know. But it's not left to the time that when they are coming to the maternity unit. It will be done when she agrees for the induction.
I'll give you further information if you want to go ahead with the admission. And if you want to take time, I can book another consultation in the next 2 or 3 days to have you here for a CTG and an ultrasound. Okay, doctor, thanks for your information. Thank you for your time.
Okay.
Hi, I'm Dr.
Okay, so I'd say good. It's a good attempt. It may be a pass attempt, okay? You have made a very good effort. Thank you, first of all. Okay, but you do need lots of input, like a UK-based input. Okay, that what happens because so many things you fluently just commit to saying them, and then they are not correct. Okay, so let's go quickly to see in this station what I would have thought that you could probably improve this station in some ways. And what would that be? That you didn't seem to have asked her about her birth plan. What was her original birth plan? If she was not, if she didn't end up in this situation, was she going to give birth at home or a standalone unit, or a midwifery-led alongside unit. Okay, so you could have asked that, because that will show you how much how much are we going to have to move her away from her original plan. Because if we stay closer, if was she already anyway going to be delivered in say alongside unit? If she was, then we could say that so it's not really, I know it's some change, but you were going to be delivered in the department next door really, and now if we have to induce you, that will be here, right in this department, in the maternity department, under the consultant-led care. So knowing her birth plan, that birth plan, if you find out her birth plan, that makes her feel comfortable as well, that you are giving importance to what she was planning and what she was thinking. Okay, so that would be good. So if it was, yes, good that you do, if I was doing the station, I'll establish rapport and I'll see why she was referred. And then you ask particular concerns, that was very good. Then I'll explore at that point, why doesn't she want any, active management? What are the fears? Then I'll go for the history, but this is acceptable in both directions. No worries at all. You can do it that way or that way. Okay. And then um, remember, you said that the best option is induction. So you would say actually that the best way would be that if labor still, starts on its own. Okay. Um, she may want to find out you, because you were your own patient, so you didn't bother yourself with those kind of questions. Patients may try to find out that are there any natural ways, can I go home and have sex with my partner and this labor will start, or there are other things like people they talk about various other formulations. If I do this, like home remedies they talk about, and you need to know from the nice guidance, what are you going to say about which option. Okay. So what is there that hasn't got any evidence behind that, and what is there that's not recommended. Okay, so you will find it in the latest nice guidance of induction of labor. I know as a patient, for yourself, you didn't ask yourself those questions, but the actual patient may end up asking those questions. Okay, so you need to know those. Asking about birth plan was a very, very important thing. Okay, check birth plan. Okay, check birth plan. That was missed. Okay. And then of course, when you check the birth plan, you can offer her a sweep, as I said, because that's closer to the nature. Okay. And then I'd say that you then tell her about both the options. What are you doing there? You will, you took the history, targeted history, would be better, excluding any cervical screenings and smoking and alcohol. That's not required there. Just check whether there's any other ongoing concern in this pregnancy. If there was, they'd probably mention. And then you ask her about, I know you're wanting to stay natural, but are you aware of what are the risks if we continue the pregnancy beyond 42 weeks? And then you'll talk about those. And mention that herbs, palsy, and all that in that. And let me see if we are forgetting anything in that. Like, we hypoxic ischemic encephalopathy, I was thinking, but even if you say that there's a risk of stillbirth and the meconium and all that, that would be fine as well. You will also need to mention that if you underwent induction of labor, you will have to have more examinations, like vaginal examinations, and your choice of the birthplace will be limited because, and of course, if she was wanting a birth in a pool, that will be limited as well, and those kind of implications. Okay. And that sometimes whatever method of induction we use, sometimes it can cause excessive stimulation of the womb, and then it can have its problems. Okay. And this induced labor can be more painful. Okay. And the hospital stay can become longer. Okay. And you can also tell her that, yes, more painful, but we have pain relief options, because you'll be in the consult-led unit. You will be offered, tell her about epidural. So, say how effective it is, and patients don't feel much pain at all. And, um, and all that kind of things. And yes, intervention rate can increase. You already mentioned that. Okay. And then of course we will tell them that you can go through this information that I'm providing to you. You can come back with any additional questions that you have. Okay. And then reassure them that if at any point you didn't want to go ahead with the induction, you felt it was unsafe, or you felt that you can't cope with the pain and you don't want it, or you wanting to still stay conservative, you can withdraw your consent at any time, even after induction. Okay. And whatever, we can stop induction, like, if there was at whatever stage we are, we can have a look and we can review and we can say, okay, um, look into your and advise you accordingly, whatever the situation might be for the baby at that time. You can also choose to go for a section, okay? Rather than going for an induction, you can straight away go for a section as well. Okay, so these kind of things will let the patient know. And you in the end, of course, we will respect her choice. That's the most important thing, that we will respect the choice of the patient. So I hope, and yes, please, we would slightly check that, do you think this information has been helpful? Okay. Would you like to consider these options, and let's discuss them again in tomorrow with your partner with you? Would that be okay? And this is how you will end this conversation. Give her whatever information is required, and finish on a unhappy, a happy ending. Okay. So I hope this is helpful. Do drop me a line if you need any further. And I'm so sorry, Entisar, if you are sending me any audios, you need to really help me with some better audio. It was extremely difficult. I tried to hear your audio 3 or 4 times, dear. So whoever is watching this, please make sure that you are good with your audio. Okay. That will help you in the exam. Okay. So bye for now, and good luck everyone with with your exam. Bye-bye.